Hi everyone, welcome and thank you for joining me tonight. My name is Dr. Lillie Luu Nguyen and I am a licensed and certified nutrition specialist with my doctorate's degree in clinical nutrition. I'm one of the clinical educators here at Vibrant and I'm absolutely delighted to be your guide through tonight's webinar of the Wheat-Zoomer Foundations from Interpretation to Clinical Integration. Buckle up because we're about to embark on an illuminating exploration in hopes to revolutionize your clinical practice as you learn how to better interpret this lab report. Are you ready? Let's get started. Here's the agenda for tonight's session. We'll begin by looking at the overall scope of the test and then dive into a detailed marker-by-marker review. As we progress, we'll look at topics like celiac disease, non-celiac gluten sensitivity, and intestinal permeability. Throughout this presentation, we'll look at the current research connecting wheat and gluten sensitivity to various other conditions. We'll go through a case study, and lastly, we'll explore resources that could be provided to patients and practitioners on how to promote gut healing and minimizing inadvertent exposure to wheat and gluten. A little bit about the Wheat-Zoomer technology. The Wheat-Zoomer employs an exceptionally sensitive, proprietary peptide-based array to offer an early assessment of the following: gluten and wheat sensitivity, autoimmune disease, and the stability of the patient's intestinal barrier, all of which is done with a sensitivity of over 99%. Furthermore, peptide testing stands out as one of several vital tools for assessing food sensitivities. It excels at identifying sensitivities regardless of the food's preparation, so whether it was cooked or uncooked at the time of consumption. I can imagine a few of us have ordered both a food sensitivity test and a Food-Zoomer test of choice for our patients before. The results make sense when there's a food item that shows reactivity on both tests, but what if you notice that someone's reacting to X, let's say that's wheat on one test, but has no reaction to wheat on the other test? Does this imply one of our test results are wrong? Not at all. It simply highlights the specific level that that wheat reaction is occurring at. So what do I mean by levels? Let's begin by comparing the Wheat-Zoomer to the food sensitivity test. While both tests have wheat markers that we can look at, the antibody response will occur at different levels. So where's the distinction? Depending on the test you choose, we're either assessing wheat at the whole protein level up here, or when that wheat protein is broken down because it's being denatured and degraded by digestion, we're now looking at wheat at the peptide level. Another way to imagine this is to pretend like the whole protein is equivalent to the whole earth, which is what Vibrant's food sensitivity test would be looking at. In comparison, a Food-Zoomer test would zoom in and look at foods at a peptide level. If we continue with the Earth analogy, it's like zooming in on individual countries that make up the whole Earth. Thus, the immune system will recognize whole proteins differently than it would recognize a peptide. And this is why you may see a reaction on the Food-Zoomer test, but the same reaction will not occur on the food sensitivity test, and vice versa. Now that we're well-versed in distinguishing between whole proteins on the food sensitivity test and peptides on the Food-Zoomer test, here's what the Wheat-Zoomer results will showcase. On the screen, you'll view all the markers that the Wheat-Zoomer includes without any additional add-ons. Add-ons would be things like the Celiac Genetics Panel or total Immunoglobulins, which is currently a free add-on to any antibody test like the Wheat-Zoomer. In essence, the Wheat-Zoomer is like 9 tests packed into one. It encompasses everything from IgE to celiac markers to intestinal permeability markers. This provides a comprehensive spectrum of possible reactivities to look over, giving you a more precise overview of your patient's results. A need-to-know basis. Sorry for the play on words. I just thought it was perfect for the slide. On a more serious note, when we're talking about wheat and gluten disorders, there are so many buzzwords used to describe the various wheat and gluten conditions, and sometimes people will unintentionally use the wrong ones. So let's clear up the basics and learn which ones we need to know. Let's begin with the main types of pathways. We have autoimmunity, allergies, and intolerances and sensitivities. Celiac disease is an autoimmune disorder triggered by gluten. Autoimmunity is when the body's natural defense system can't tell the difference between your own cells and foreign cells, causing the body to mistakenly attack perfectly healthy cells. And in the case of celiac, it will attack and damage the cells in the small intestine that may then lead to things like bilious atrophy. Wheat allergies are an IgE-mediated response to wheat proteins. Here, the immune response is involved, but does not usually attack one's own body, so it's not autoimmune. When it comes to intolerances and sensitivities, they're often used interchangeably because they can produce similar symptoms. However, the difference lies in the immune involvement. Sensitivities often have an IgA or IgG immune response, whereas a food intolerance does not involve an immune response at all and is more accurately characterized by the body lacking a chemical or enzyme needed to digest down a certain food. So this can be applied to both wheat and gluten. For non-celiac gluten sensitivity, it mirrors many of the celiac disease symptoms. However, it would come up negative in a blood test and/or biopsy when we're looking for celiacs because non-celiac gluten sensitivity lacks the autoimmune aspect that would cause intestinal damage. Additionally, some studies show that non-celiac gluten sensitivity has an immune response that's distinct from celiac disease. So in summary, celiac disease involves an autoimmune response to gluten, wheat allergy is an IgE immune response to wheat proteins, and all the others are going to be terms used to describe varying degrees of immune involvement and adverse reactions to gluten or wheat, ranging from mild discomfort to severe. Here's the first thing that we'll cover on the wheat zoomer, the wheat allergy panel. This will populate on the report if the sample was collected via venipuncture, aka blood draw. Wheat allergy involves IgE allergic reactions to foods containing wheat proteins, as we just discussed. Your body produces antibodies against any of the 4 classes of wheat proteins, such as albumins, globulins, gliadins, and/or glutenins. The reactions can stem from both consuming wheat and, in some instances, inhaling wheat flour. Your body fights off foreign invaders with antibodies, aka immunoglobulins. We just talked about IgE, aka immunoglobulin E, which is considered the true food allergy antibody, where responses will usually cause someone to have an immediate reaction. The wheat zoomer also has a few other antibodies that it utilizes. We have IgM, which is the first antibody to come to the scene when someone has an infection. IgG is systemically driven and can impact anywhere in the body. It's considered the memory antibody, and when someone has elevated IgG, it indicates that exposure might have happened in the past 3 to 6 months. And this is because IgG has a variable half-life of about 1 to 3 months. Note that this half-life is highly variable depending on the person. IgA is mucosally driven and often associated with digestive and respiratory issues, since it's found in the GI tract, tears, saliva, and sweat. Elevated IgA levels will indicate that exposure was present recently, with a half-life of about 6 to 8 days. Next up, we have the celiac panel. Please note we are not diagnosing. Any reaction detected is an indication for celiac, but from here, additional testing is needed to reinforce and support the findings. Let's begin with tissue transglutaminase 2, aka TTG2. This is the main traditional biomarker for celiac that is most often used in serological testing for celiac diagnoses. IgA tends to be more diagnostic of celiac, whereas IgG is indicative of celiac progression, especially if there's a low total IgA. Some patients may have no GI symptoms present. However, tissue transglutaminase 2 can sometimes be elevated in other autoimmune conditions. So be sure to take the entire clinical presentation and medical history into consideration alongside the lab results. Deaminated gliadin peptide is another traditional biomarker for celiac disease. It does not need to be elevated for a diagnosis if other markers such as tissue transglutaminase 2 are elevated. Additionally, you do not need to have both tissue transglutaminase 2 and deaminated gliadin peptide to be elevated for a celiac diagnosis. Consider this. Currently, about 1% of the United States population holds a diagnosis for celiac disease. That doesn't sound like a lot, but to put the numbers into perspective, that's 1 out of every 100 people. So if we're taking into account the current US population, that's more than 3 million people with an official diagnosis. If that many Americans have celiac, how do we determine this earlier? How can we make sure that we start preventative care sooner than later for other patients that are possibly heading in the same direction? That's where the wheat zoomer's fusion peptide, aka the In the Future panel, comes into play. When tissue transglutaminase becomes cross-linked to deaminated gliadin peptide, it essentially is fused into one complex, hence the name fusion peptide. This biomarker gives practitioners a glimpse into celiac disease progression, with a window for possible indicators appearing earlier than traditional lab markers would show. In other words, this panel can help practitioners figure out if their patients are on the road towards developing celiac disease. IgA is more predictive of the potential development of celiac disease, but regardless of IgA or IgG being moderate or positive here, results may suggest that now may be a good time to implement dietary and lifestyle interventions. According to the Mayo Clinic, many with celiac disease don't realize it. There are 2 blood tests to help diagnose it. The first is serology. We just went over the 2 most common traditional biomarkers, with tissue transglutaminase 2, IgA, being the main marker to look out for. The other blood test is genetics, which will check for HLA-G2 and HLA-DQ8. Having positive results for HLA-DQ2 and or HLA-DQ8 doesn't guarantee celiac disease. The genetic test shows a person's potential for the disorder, but doesn't diagnose it. More than 90% of celiac patients will have HLA-DQ2 or HLA-DQ8 genes. However, only 3 out of every 100 people with these genes will go on to develop celiac disease. In other words, while many with celiac have these genes, not everyone with these HLO genes will go on to develop celiac. That is because the genes alone are not enough to develop celiac. An environmental trigger is often necessary, and this trigger can be a really stressful event, illness, surgery, pregnancy, etc. Genetic testing can only rule out celiac disease. It cannot concretely diagnose it. There are rare exceptions, however. Some people without these genes can still develop celiac, but again, this is very rare. Usually, if someone lacks HLA-DQ2 and HLA-DQ8, celiac is very unlikely and excludes it as a diagnosis. After running blood tests that suggest celiac, further testing is warranted. Remember, this is just the starting point. Ordering blood tests is the first piece of the puzzle. For a stronger confirmation, a biopsy is often necessary for an absolute celiac diagnosis. Here's a closer look at the National Celiac Association's diagnostic process to help you visualize the step-by-step nature that is involved. The section highlighted in yellow is where Vibrant's wheat zoomer could be a valuable assistance to you when you're on the serological testing step. As a gentle reminder, if a gluten-free diet is advised, please make sure to replenish any nutrients such as vitamin D, B12, folate, and other micronutrients that may be lowered due to avoiding certain foods on this diet. To summarize what we've learned so far, Vibrant Celiac Panel covers many of the main biomarkers that are often used for assessment, but other tests can be ordered to strengthen the evidence for a celiac diagnosis, such as celiac genetics, total serum IgA or total immunoglobulins, which can check for IgA deficiency. If total IgA is low, it may cause false negative tissue transglutaminase IgA results. There's also IgA endomysial antibody, EMA. According to the Celiac Disease Foundation, the EMA test has a specificity of almost 100%, making it the most specific test for celiac disease, although it's not as sensitive as the tissue transglutaminase IgA test and can be considered very expensive to run. Again, after blood testing or genetic testing showing signs of celiac disease, a biopsy can confirm an official diagnosis if there's villus atrophy, damage, and/or inflammation. Skin biopsies may also be ordered to assess for dermatitis herpetiformis because it's often associated with celiac. And while micronutrients are not part of the diagnostic process, it's helpful to know if a patient needs a boost in certain vitamins and minerals before, during, and after a gluten-free diet. Next up, we have the Comprehensive Intestinal Permeability Panel, which I feel is the most intricate facet of the wheat zoomer. Let's start off with some key concepts. Within the small intestine, there's a single layer of cells called villi, and these are organized in a wave-like formation. These villi will sport hair-like projections known as microvilli that sit underneath a mucus layer. Together, this top portion makes up the intestinal epithelial barrier. Now, although the small intestine measures just about 22 feet in length, its wavy structure grants it an immense surface area, so much so that it's equivalent to a tennis court. So why do we need that much surface area? To increase nutrient absorption. But we have to be very particular about what we do and do not allow through this barrier as we're absorbing things. If we observe the small intestine under a microscope, it resembles a cheesecloth or a fine mesh. Small openings are perfect for allowing essential substances like sugars, amino acids, and fatty acids to enter the body while effectively excluding any harmful elements. Maintaining the right level of permeability is facilitated by tight junctions, which will keep cells closely connected together. However, there are instances when the openings in this cheesecloth will enlarge, permitting undesired substances like undigested food and bacteria to pass through. We often think of intestinal permeability as leakiness, but it's better described as how well the gut controls what passes from inside the digestive tract through the gut lining. The intestinal barrier is naturally somewhat permeable. It allows the essential substances like water and nutrients to pass through while blocking harmful stuff. This can be considered intestinal permeability. However, when the gut barrier becomes excessively permeable, it acts more like a permeable membrane, and this means it allows more things, including potentially harmful ones, to pass through. We commonly refer to this as intestinal hyperpermeability. This can be conceptualized by the 3 panels seen here. The first is an impermeable membrane where nothing gets through. The semi-permeable membrane, like our gut, is selective and allows the good stuff through while blocking the bad. Then there's the permeable membrane on the third panel here, where it lets many things pass through without being selective. When our gut barrier becomes hyperpermeable, it behaves like a permeable membrane, letting more things pass through than it should. Here's a visual depiction of the intestinal barrier at various stages. In the first panel, we have the gut bacteria living in balanced harmony. Then if any imbalance occurs in the gut microbiome, this can cause dysbiosis that starts thinning away at the gut barrier. And if dysbiosis isn't addressed sooner than later, it can lead to leaky gut that allows the unwanted microbes and particles to pass through that we discussed. Tight junctions are like flexible gates in our gut lining. They can change the shape when needed, and they must do so quickly and in coordination with each other. This relies on a complex system that guides how these gates are assembled. Zonulin and tight junctions are going to work very closely together. Zonulin is like the gatekeeper to the tight junctions. It's a signaling molecule that tells the gates to open up all along the GI tract. Zonulin tells specific proteins within the tight junction complex to reorganize and shift themselves around. This makes the tight junctions more flexible and allow for larger openings for things to pass through. This process of opening the gates is like a safety feature. It helps flush out potentially harmful microorganisms and assisting the body's immune system against bacterial invasions in the small intestine. Recent research suggests that the body sees gluten as a potential threat, similar to how it reacts to bacteria. So when zonulin gets activated, it's not just about the bacteria, it can also relate to how the body responds to gluten. So in a nutshell, tight junctions are like flexible gates in our gut that can open up under the guidance of zonulin, serving as a protective measure against invaders, including potentially harmful microorganisms and even substances like gluten. When zonulin is found in the stool or blood, it indicates recent zonulin release. Therefore, zonulin can act as a biomarker for impaired gut barrier function in autoimmune, neurodegenerative, and tumoral diseases. It can potentially be targeted therapeutically for treating these conditions. Among the various stimuli that trigger zonulin release in the intestinal lumen, the most potent ones identified are going to be exposure to large amounts of bacteria, aka bacterial overgrowth, especially of the gram-negative kind, and gluten, which I've bolded here on this list so that we can take note of it again in a few slides. Okay, let's jump back to the test. When zonulin is present in the blood or stool, we know it means something recently triggered zonulin release. Did you know that the blood-brain barrier also has zonulin receptors that zonulin can bind to and then open up the tight junctions of the brain? This can cause what's known as leaky brain. Note that zonulin levels are just a snapshot in time. We will often see a normal zonulin level because zonulin is just like your heart rate or blood pressure, and it fluctuates throughout the day. It can fluctuate from non-detectable to being upregulated within minutes to hours. On the screen, right under zonulin, you'll also see something called anti-zonulin. What's the difference between zonulin and anti-zonulin? Zonulin is a signaling protein, and anti-zonulin is an antibody. Zonulin provides feedback of a snapshot in time, whereas anti-zonulin is like a report card. When we develop antibodies to zonulin, it provides evidence that we've had chronically elevated levels of zonulin in the past. So what can we do if we see high zonulin or high anti-zonulin? Heal the gut and remove any of those zonulin triggers that were shown a few slides back. Now let's explore anti-actin, a marker that reveals the extent of intestinal damage. Actin is crucial for the microvilli because it aids in cell growth, division, and repair. It anchors the microvilli to the cell membranes, links intestinal cells, and regulates the paracellular flow between cells. Elevated anti-actin levels will suggest that there are small tears in the smooth muscle fibers of our gut, which can be an indicator that epithelial cells have been damaged from intestinal permeability, and now we have reduced barrier function. If there's a higher transcellular permeability, aka meaning through the cells, consider checking for dysbiosis. High anti-actin is also linked to connective tissue conditions like chronic pain, injuries, and tendinitis. To further add to the connective tissue comment, despite being separated entities, rheumatoid arthritis and celiac disease share multiple aspects in epidemiology and clinical manifestations. For example, celiac disease patients have been observed to have more rheumatic symptoms than their normal counterparts would, and people with rheumatoid arthritis are more likely to have celiac disease. Thus, there may be some correlation here. If you are interested in seeing what the connection is between wheat and joint health, Vibrant conducted and published the following study and found that there was an overlap between those who had positive wheat Zoomer antibodies and those who had rheumatoid arthritis. Looking beyond rheumatoid arthritis, wheat-related issues have a connection to autoimmune health as a whole. And gluten is known to mimic thyroid antibodies, possibly contributing to autoimmune thyroiditis. And going gluten-free has been showing promising results in lowering autoantibodies, as seen in the meta-analysis on the screen here. However, celiac disease isn't just linked to the well-known autoimmune disorders like Hashimoto's and Graves' disease and rheumatoid arthritis. Research from Vibrant's paper here suggests that celiac disease is also associated with more than just those autoimmune conditions, and it's beyond what we thought because it can be linked to Addison's disease, autoimmune insulin-dependent diabetes, Sjogren's syndrome, and autoimmune hepatitis. Overall, it may be reasonable to speculate that removing gluten from the diet of autoimmune patients might help improve their symptoms by reducing chronic intestinal inflammation, and in turn, this can reduce gut permeability and the subsequent triggers for systemic autoimmune inflammation. However, more evidence is always needed to confirm this. Here's an interesting observation. Having an earlier diagnosis of celiac can lower the chances of developing another autoimmune disease later on. A patient's chance of developing another autoimmune disorder is 10.5% when they're diagnosed between the ages of 2 and 4 years old. This risk will increase to 16.7% if you're diagnosed between 4 and 12, to 27% between ages 12 to 20, and up to 34% if diagnosed at 20 years or older. If we're trying to determine a person's risk sooner than later, some good news to note is that the wheat Zoomer is validated in not just the adult population, but also in the pediatric population. So when the wheat Zoomer is ordered for a patient that's aged less than 18 years, the test report will automatically be adjusted to reflect pediatric reference ranges. Next up, we have lipopolysaccharides, aka LPS. These are an indicator of dysbiosis-mediated leaky gut. LPS is not a tight junction protein, but rather a potent endotoxin found on the outside layer of gram-negative bacteria. It's released either when the microbe dies and the cell membrane degrades, or as a defense mechanism in response to a threat. LPS mediates inflammation by binding to receptors on the epithelial cells and then initiates a cascade of inflammatory responses. Under normal circumstances, little to no LPS should be translocating across the epithelial barrier. But when that barrier is impaired, LPS will gain access to the circulatory system, and only with intestinal permeability will LPS enter that bloodstream and then cause our body to make LPS antibodies that can then lead to things like endotoxemia. When it comes to LPS, IgA is a more exact and acute measure of LPS that's coming from the intestinal tract because if you recall, IgA is found in the mucosal lining. Anti-LPS IgG plus IgM indicates that LPS is recognized by the immune system as a sign of a bacterial pathogen invasion because IgM indicates that you're fighting an infection. So what do you do when you see high LPS? Consider a gut Zoomer. Recall that high LPS can indicate higher populations of gram-negative bacteria present in the GI tract. You may also want to consider checking for additional clinical labs like cardiovascular disease markers, inflammatory markers, blood sugar, and insulin resistance, because lipopolysaccharides are thought to be involved in cardiovascular disease by promoting lipid accumulation. The connection between wheat and cardiovascular health can be seen here in this Vibrant study, where participants with positive wheat Zoomer antibodies were associated with having altered blood lipid levels. Taking all that we just learned, how do these all relate to each other? Well, with higher zonulin levels leading to more intestinal permeability, this facilitates the entry of bacteria, leading to more gut dysbiosis, and then that's going to lead to higher LPS in addition to other food antigens and possibly more. In turn, this produces chronic subclinical inflammation. And this cycle repeats itself until we get that gut barrier mucosa sealed up and healed up. Here's another interesting consideration when it comes to leaky gut. We all know that regular aerobic exercise offers many physiological benefits. It enhances the cell's ability to handle stress, and this is a fundamental concept in how exercise conditions the body and promotes long-term adaptations. However, recent studies are suggesting that exercise intensity may matter. Intense endurance training, defined by this study as exercising at 70% or more of your maximum work capacity for more than 60 minutes, might potentially increase intestinal permeability. This effect has been observed mainly in ultramarathon and triathlon athletes. These athletes have experienced heightened gut permeability and inflammation, especially when they're in challenging conditions like hot environments, high altitudes, and under dehydration. Alas, there is no precise exercise threshold established for causing hyperpermeability. The research hasn't pinpointed the exact level of exercise that leads to this condition yet. But on the whole, low to moderate exercise is unlikely to induce leaky gut, and it offers more numerous health benefits than not. However, it is still vital to personalize exercise recommendations to each person's tolerance level. Excessive exercise may be harmful to some patients, but more research is needed because every individual's response will vary widely. Knowing that leaky gut may be present is a great starting point to focus someone's intervention on because it can have so many downstream effects. That could be things like food sensitivities, bacterial infections, leaky brain, leaky skin, joint issues. So if you're seeing anything off in the intestinal permeability of the wheat zoomer, it may be valuable to look at other tests like the gut zoomer, complete food sensitivity, connective tissue, also known as the autoimmune panel, just to name a few. Next, we have the transglutaminase panel, which indicates gluten-mediated autoimmunity. These are markers of autoimmune reactions to gluten that are not celiac. Gluten is still the trigger for these reactions, but they manifest differently than the traditional celiac that we saw earlier on. Both transglutaminase 3 and 6 are associated with gluten sensitivity, but it's not going to be the same as the transglutaminase 2 that was in the celiac panel. Transglutaminase 3 is associated with skin manifestations of autoimmunity, such as dermatitis herpetiformis, eczema, and psoriasis. Note, if someone has skin issues and this is negative, gluten sensitivity could still be the issue. However, transglutaminase 3 specifically isn't the cause of their skin issues. Studies have found that it may be appropriate for some patients with skin manifestations to trial a gluten-free diet. Dermatologic conditions that may respond positively to a gluten-free diet include things like psoriasis, atopic dermatitis, and vitiligo. Then we have transglutaminase 6, which is correlated with neurological manifestations of autoimmunity in the cerebellum, such as gluten ataxia, gait abnormalities, balance and coordination issues, brain fog, anxiety, and depression. In fact, there are multiple wheat zoomer markers that have been found to be having an association or a strong link to the antibodies tested on Vibrant's NeuroZoomer Plus. Thus, if you notice your patients complaining of neural or cognitive issues and they're still consuming gluten-containing grains, consider this test to further investigate possible correlations. Now we have the wheat germ agglutinin. This is the lectin component of wheat, and it's separate and different from the gluten and other non-gluten proteins that are in wheat. Lectin is a plant's defense against things that want to attack it, like insects and large animals. Plants can't run away, so instead, when something wants to eat it, the plant's lectin makes the animal feel sick and have GI distress. In fact, when bugs try to eat a plant, the lectins in that plant will bind to the insect's gut epithelium, hemolymph, or other tissues in that bug, and eventually cause that insect to die by inhibiting the absorption of nutrients. Pretty interesting, right? So how does the lectin known as wheat germ agglutinin affect us? Wheat germ agglutinin is commonly used as an additive in supplements, and yet it's still considered gluten-free because it's a different protein structure. For some people, lectins can be considered anti-nutrients due to their inflammatory and autoimmune associations. Wheat germ agglutinin can trigger inflammation through immune cells and can breach the intestinal barrier, thus facilitating the translocation of bacterial endotoxins across this barrier. It's important to note that most lectins can resist heat and the effects of digestive enzymes. However, one interesting study suggested that sourdough fermentation may reduce the amount of wheat germ agglutinin, but more research is needed to be done regarding this method. There's also some research to show that wheat germ agglutinin can compete with vitamin D for absorption. If that's the case, a patient may need to have higher supplementation until they see improvement. So if someone has a sensitivity to wheat germ agglutinin, you may consider the micronutrient panel to look at vitamin D status. Additionally, note that not all individuals who react to wheat germ agglutinin will have to follow a low lectin diet. To substantiate the need for a low lectin diet, consider the lectin zoomer to see if there's other foods that they're reacting to in terms of lectins. For those of you who may not know, Gluten is made up of two proteins, gliadin and glutenin. When hydrated, they interact to form a gluey substance called gluten, and this is what allows bread to be airy and chewy. Gliadin tends to be the more reactive portion of gluten for most people. It has the most research behind it because it can bind with tissue transglutaminase 2 that's involved with celiac, and it can bind to zonulin to precipitate leaky gut. Vibrant's gliadin panel tests for reactivity to 4 forms of gliadin: alpha, alpha beta, gamma, and omega. And it also tests for 2 forms of glutenin, which is high molecular weight and low molecular weight glutenin. Glutenin is the other part of gluten, and it's less commonly reactive than gliadin is, but some people can react to glutenin without any reactivity to gliadin. This panel looks at the full spectrum of reactivity of glutenin from high to low molecular weight. High molecular weight is associated with atopic dermatitis, asthma, and wheat sensitivity. Low molecular weight is associated with the same things as high molecular weight, but it also has hives and anaphylaxis on its list. There's no clinical difference in outcomes between antibodies of high molecular weight and low molecular weight glutenin. At the end of the day, if someone's reactive to anything in this panel, a gluten-free diet is recommended. The remaining markers in the gliadin panel are gluteomorphin and proteomorphin. Gluteomorphin, also known as gliadorphin 7, is an opioid peptide with an affinity for opioid receptors in the central nervous system and the enteric nervous system. Gluteomorphin is released following the enzymatic hydrolysis of alpha-gliadin through food processing or digestion. So what's the impact on the central nervous system? Gluteomorphin can be transferred across the epithelium of the intestines and then transported via the bloodstream and then cross the blood-brain barrier where it can exert its opiate-like effects, morphine-like activity in the central nervous system. Their enteric nervous system regulates their gut and is often called their body's second brain. Gluteomorphin and other food-derived opioids can act in the intestinal lumen and in our intestinal mucosa. Here, they have an effect on the intestinal motility and gastric and pancreatic secretions, similar to what opioids would do. Other compounds in wheat with opioid-like activities will be glutenin, which can then degrade into gluten exorphins. These peptides can cause the feeling of euphoria and happiness when you're eating the gluten foods. So an elevated gluteomorphin can indicate that if gluten is removed from their diet, they may have a much harder time withdrawing from gluten when they're eliminating it as they start a gluten-free diet. Luckily, this feeling will pass in about 2 to 3 weeks. Helping patients be aware of this and knowing that it's normal and temporary can help them go gluten-free. When it comes to proteomorphin in particular, it can cause symptoms like brain fog and mood issues like depression or poor emotional control. This is an important marker for kids, so before starting them on any ADHD medications, consider running a wheat zoomer on them. It's been noted that patients with obsessive compulsive disorder also demonstrate a significant level of antibodies to proteomorphin as well. So what can we do if these opioid-like peptides are high? Make sure that they can be broken down. One way to do so is via DPP4, a protease known as dipeptidyl peptidase 4. Dipeptidyl peptidase 4 plays a crucial role in the breakdown of small peptides to form dipeptides and tripeptides that can then be transported across the intestines more easily. Breakdown of these exogenous peptides result in inactivation of their opioid activity. There are some big-name companies that do carry supplements for dipeptidyl peptidase 4 as well. Given what we have learned, let's take a quick break to do a mini quiz. I'll give everyone a moment to put their guesses in the chat. Which of the following is or are usually gluten-free? All right, all guesses in? If you guessed rice, you are correct. All the other ones listed here contain gluten. The glutinous term refers to the sticky nature of rice and not the actual gluten that's usually found in wheat, barley, and rye. Roux is usually a mixture of butter and wheat flour. Soy sauce is usually made from fermented and crushed wheat and soy in a salty brine. You can have some gluten-free soy sauce options that are going to be things like tamari or coconut aminos. Couscous is a type of pasta made from semolina, which is a flour made from wheat. Malt vinegar is fermented and made from barley. And lastly, most beers contain gluten because they're made with either wheat, barley, and rye. Of all the proteins in wheat, did you know that gluten only makes up 75% of the peptides? The remaining 25% is made up of other non-gluten wheat proteins. Part of the Vibrant Advantage is our non-gluten wheat panel. Other proteins in wheat that are not gluten are going to be things like serpins, farrinins, amylase and protease inhibitors, globulins, and purinins. These non-gluten wheat proteins can cause inflammation due to a wheat sensitivity, and some people are actually more reactive to wheat proteins than they are to gluten itself. So based on these results, you can help the patient decide if they should be gluten-free and or wheat-free. That sounds the same, right? However, a wheat-free diet does not necessarily mean a gluten-free diet. Wheat-free diets and gluten-free diets have a lot of overlap, but there are a few subtle differences. A wheat-free diet is looking to avoid wheat and any wheat derivatives. So think about wheat starch, wheat germ oil. But since that technically still permits barley and rye, foods like pumpernickel bread made from rye, for example, can still be part of that wheat-free diet, meaning that gluten may still be present as long as it's not from wheat. Whereas a gluten-free diet avoids all gluten-containing grains, meaning no gluten will be present. But what if a food company makes a product like this baked good here and labels it as a gluten-free wheat starch? That wheat starch may have been processed so that they remove gluten from it, but if they're wheat sensitive and they're reactive to other proteins that are not gluten, they may still have symptomology. Thus, an extra layer of caution may be required when you're on the lookout for hidden sources and or contaminated sources of gluten and wheat. It's not just in foods, but it's in common day items and products like supplements, personal care products, etc. So while the product might say it's gluten-free, if a person is wheat sensitive, ensuring that there are no non-gluten wheat proteins is also crucial. For example, here we have a shampoo and conditioner that still contains wheat in them. Note that the U.S. Food and Drug Administration, the FDA, enforces a U.S. law to require any foods or ingredients containing a major food allergen be specifically labeled with that name or allergen source. And if you look at the screen here, there are 9 allergens that have mandatory labeling as of January 1, 2023. However, gluten is not one of them. If a product voluntarily claims itself to be gluten-free on the package, then the FDA enforces that that product must contain no more than 20 parts per million of gluten in order to carry that gluten-free claim. And this has been deemed a safe limit for celiac patients. So if you're taking someone off of wheat and gluten, it's helpful to also run a grain zoomer and a corn zoomer, because when someone has reactivity to either the gluten or non-gluten wheat panel, they very often have a reactivity to other types of grains, especially corn. So providing patients with viable alternatives to wheat gives them a peace of mind, because they can see with hard data what alternative grains they are or are not reactive to. We're almost at the end, so bear with me. I know we all love a good case study, so here's some background information on a textbook case. We have a 19-year-old male who just found out his mom was diagnosed with celiac last year. In the past, he never had any trouble with gluten himself, but when he went off to college, he started eating typical college foods and drinks. And after about a year, he started noticing he gets really bloated and has very poor bowel movements. He's always hearing about going gluten-free, especially now that his mom has it. So he tried to do the same without any professional nutrition guidance, but notices that he still gets an upset stomach when he eats gluten-free things. So he decided he needed an actual health professional to look into this. That ordering provider ordered this test and wanted to check the patient's blood work to see if celiac was at play or if it was due to something else before meeting with this patient. The first step is to check for immunoglobulin deficiencies in IgA or IgG. These deficiencies could impact the results and require a different interpretation. In his case, the patient's immunoglobulin levels are within normal range, so we can interpret the results as presented. For celiac HLA genetics, it's beneficial to run this test to rule out genetic influences on celiac disease risk. The patient is positive for DQ2, but negative for DQ8, indicating a slightly increased risk for celiac, but I want to know more evidence to confirm this. Next, we have the summary of the Wheat Zoomer results. This is the first page on the Wheat Zoomer report, and it offers an overview of the patient's reactions in each panel and highlights what they're also not reactive to in the negative section. Further down the report, the patient shows moderate and high reactivity to tissue transglutaminase 2 and deaminated gliadin peptide. the key biomarker for celiac disease. Combining this with the presence of HLA-DQ2 gene and the markers in the celiac panel, it suggests a stronger case for possible celiac. However, we still need to continue and explore the rest of the test for additional insight. Next, we have the intestinal permeability panel. The patient exhibits indicators of leaky gut and gut barrier damage with the elevated anti-Zonulin and anti-actin levels. We want to think about the possible factors that could have led up to the patient's results here. Could it have been their college diet, alcohol consumption, academic stress, all of the potential contributors to hyperpermeability? Looking at his anti-LPS, he's within the normal range, but it's worth noting that his anti-LPS IgG-IgM is trending towards the upper end here, so perhaps he might want to look into a stool test to reveal if a gut infection is developing. Then we have transglutaminase 3 and 6. Despite the absence of the patient reporting any symptoms of skin or neurological issues on his intake form and having a normal wheat germ agglutinin level, if you note, these markers are close to the upper end of their normal range. So perhaps consider a nutrition-focused physical exam, assess for any kind of related issues to skin and neural issues, and check for vitamin D status. Maybe reactivity to other lectins could also be explored. Recall that gliadin and glutenin are the two components that make up gluten, and reactivity in any of these panels will suggest that a need for a gluten-free diet is warranted. Since he's already on a gluten-free diet, I'd investigate the patient's adherence. Are there occasional exceptions or accidental gluten ingestion at restaurants? Ensure that the patient is aware of any hidden sources of gluten. Lastly, this panel may explain his persistent GI problems after going gluten-free. Non-gluten wheat proteins are still present in some gluten-free foods, as we discussed, especially if they're not adequately processed out. So he may still be exposing himself to antigens that he's sensitive to. So we'd want to educate the patient on the nuances of a wheat-free and gluten-free diet. Given all these results, we have some strong pieces of information that fit the celiac picture. But to know for certain, I would refer him out to a gastroenterologist along with these results to ask if a biopsy is warranted and/or to refer to his PCP to rule out any other autoimmune conditions that may be going on. In the meantime, we can continue directing him to gluten-free and wheat-free resources to help buffer his gut lining. Currently, there's no pharmaceutical treatments or cures for celiac disease. A 100% gluten-free diet is the only existing treatment for celiac disease or non-celiac gluten sensitivity today. Telling someone to go gluten-free may be daunting if they don't know where to start. Luckily, there are plenty of resources that could be provided. Here are some common gluten-free brands. Granted, the brands available to you and your patients and me will vary by location, so there's so many new ones popping up in the grocery stores each passing year. I would love to hear if anyone has a favorite brand, whether it's local or national, that dedicates itself to being gluten-free in the chat. I'm sure your peers would all be appreciative of any little nugget of wisdom you can share with them. Here are several popular apps available to those with gluten sensitivity or celiac disease. And you can use these apps to check for items that contain gluten in the store, restaurants, or they just need a good gluten-free resource to start off with. Some of the best resources would be to look into organizations that have dedicated advocates who stay up to date on their education and research. There are way too many to list, but here's a couple of resources you can consider. Some of them will have pages for health professionals. Others will list out meal plans and delivery services that you can offer to your patients, while others, like the National Celiac Associations, can help you look up nearby chapters where you can find gluten-free restaurants, bakeries, etc., specific to your area. Additionally, some vibrant resources we have available to you are going to be the following. We have the Wheat Zoomer sample report, the markers list, key clinical messages for providers, one-pagers for patients. We have a leaky gut protocol and a beautiful intestinal permeability infographic. And all of this can be found on the Vibrant Wellness website linked at the bottom of this slide. All right, thank you all so much for your time, and I hope this webinar has helped you gain more insight on clinical pearls and confidence on how to interpret the Wheat Zoomer test. I am now open to any questions you may have.